Good morning. Welcome to our online event, the latest in PD Research 2024. And we're also throwing in a little caveat of sleep, which will be kind of exciting for some of you. Today's program is brought to you by Parkinson's Community Los Angeles. Today, we're so fortunate to have with us Dr. Jeff Bronstein. I'm Judy Yaris, PCLA Vice President. For those who don't know us, we're a nonprofit that supports families living with Parkinson's, and we do this through our free education programs like this one, online and in-person support groups, we have 16 altogether, social events, and so much more. Today's conversation is brought to you by our generous sponsors, Abbott, Acadia, and Boston Scientific, and by important donations from people just like you in the Parkinson's community. If you appreciate our programs, please consider being part of our August fundraising campaign. By making a donation at PCLA.org, your donation is 100% tax deductible. So thank you in advance. We rely on your generosity to help us continue this important work. All right, so please join me in welcoming Dr. Jeff Bronstein. Our presenter today, Dr. Jeff Bronstein, received his MD and PhD from UCLA as a recipient of the Medical Scientist Training Program Award. He completed a residency in neurology and fellowship training in movement disorders at UCLA and a postdoctorate fellowship in molecular biology before being appointed as an Assistant Professor of Neurology. Dr. Bronstein was later appointed Director of the Movement Disorders Program at UCLA. His interests and expertise include the management of Parkinson's and other movement disorders, surgical treatment of PD, and developing new therapies for patients. Dr. Bronstein's laboratory studies the cause of PD using cell models and a newly developed zebrafish model. His work is supported by the NIH and private foundations. Dr. Bronstein also directs clinical trials in order to develop new therapies for PD, and that include transplantation and deep brain stimulation. He has received several awards and is widely published in the field. Dr. Bronstein, I am turning it over to you. Thank you.
Thanks so much for such a kind introduction, and always great to see a lot of friends online now. So I was originally asked to talk about sleep, and then I learned there was a lot of questions and answers. So I think I'm going to spend just a few minutes at the beginning talking a little bit about sleep and what are the issues and why it's so important. Then spend most of the time answering questions. I don't have any real conflicts. I don't do any consulting or promotion of any drugs, but I am involved in some clinical trials, and some of that stuff may come up today, and I'll tell you what my role has been, but I'm not promoting anything, and I don't take any money from pharmaceuticals to promote stuff. So I want to start first with sleep, because it's really important, and probably more important than most people think, especially in Parkinson's disease. So there are many issues. So just for the population without Parkinson's, obviously sleep is important. You know, you feel better when you have a good night's sleep. You know, everybody estimates 7 to 9 hours is about the right amount, though everybody's a little different. There are genetic controls of the morning people. There's some people that just naturally get up at 5 and feel great. And then there's others of us that struggle to get up in the morning and drink lots of coffee like I am to keep going. So it's not just important to sleep because you feel better. Absolutely you do feel better, but chronic lack of sleep leads to a higher rate of dementia, heart disease, all kinds of problems. Stroke goes up. So it's really important. And in Parkinson's or other diseases like Parkinson's, like Alzheimer's or whatever, that share some underlying commonalities in how the pathogenesis of these diseases happen, it's particularly important. So let's just talk, list a few of the issues. So the most common one is insomnia, having problems falling asleep or staying asleep. Falling asleep, um, we have lots of, the most important thing for any of these problems with insomnia is what we call sleep hygiene. It's just doing the right things. It's getting to bed at the same time. It's getting a lot of light during the day, nice quiet room, and really having a routine, limiting your stimulants like coffee and caffeine later in the day. Common sense stuff. It's really important. Staying off of technology is probably one of the biggest ones. The blue light is thought to be one of the problems, but just engaging in anything like that will make you wake up and not be able to sleep. So really important to do what's called good sleep hygiene. Um, we have medications, and there are medications that are very short acting, which help you fall asleep. Ambien is one of those. And then there are longer acting ones that help you stay asleep. Um, Lunesta is one of those. And then there are ones that are actually pretty good at both. Most of the longer acting ones are pretty good at helping you fall asleep, as well as stay asleep. So those are important. I'm going to get back to the importance in a second. I just want to talk about a couple things that are specific to Parkinson's. It's called REM sleep behavior. So that's when people scream and act out their dreams. Um, this is very common in Parkinson's. It's common. It actually precedes the disease in many people, in quite a high percentage of people. It's actually the beginning of the disease, but it may be 10, 15, 20 years before you get your first tremor or diagnosed. So it is a predictor of getting Parkinson's disease or something related to that. It's not dangerous other than you could fall out of bed, but it's dangerous to bed partners. It can punch and kick. It happens during the dreams. And what's happening is there's a disconnect. Normally, our brain is really active during dreams. It does all the things that is when you're awake. Just we have a special part that helps turn off your body, helps you prevent acting it out. And in Parkinson's, it doesn't always disconnect. So you end up acting out what you're dreaming. It's important for the safety of your bed partner to treat it. So that's something you always ask the spouse or significant other if this happens. And we have a variety of treatments. The most effective is called melatonin. Working your way up to about 12 milligrams is necessary, and that helps most people. If that doesn't work, there's a medicine called clonazepam, which also can help. That's in a class of drugs called benzodiazepines that can be a bit addictive. You got to be a little careful how much you use and over a long period of time. So we tend to want to go with melatonin first because it's the safest. A lot of these medicines that we use, some of them are habit forming and some aren't. So we try to go with the non-habit forming ones if we can. Um, so that's REM sleep behavior, and important to recognize and very common. The other, what we call parasomnias, is sleep apnea. So that's when people are not breathing enough when they're sleeping. They'll either have pauses, and then people have a big gasp. Often people are snorers. There's a couple types of sleep apnea. It's called obstructive, and others called central. Not important the difference, but it's important to recognize it. Your brain likes oxygen. It does better with it. And people that have sleep apnea, if it's untreated, have a higher incidence of heart attack, stroke, and dementia. It's very clear. The quality of the sleep is very poor when you have sleep apnea. So people are really tired during the day. And it's one of the more common reasons that people have what we call excessive daytime sleepiness. They're tired because they're not getting a restful sleep. And that's because their brain isn't getting oxygenated at night. So very important to test for that. If there's any suggestion, a loud snore, people that are really tired during the day, If the bed partner notices they're not sleeping, they're not breathing for periods of time, those are all warning signs. Historically, it's usually people that are overweight. And quite often, if you lose weight, you can get rid of the CPAP machine, which is a good motivator because most people don't like them. It's uncomfortable, it's a mask, and it helps you breathe. But it's worth using, and you have to go through all different masks. You have to work with your sleep specialist till you find something you can tolerate. It's really important to use it if you have sleep apnea. There are some devices for some of the obstructive types of sleep apnea where they can have a mouthpiece that sometimes helps. And there's this relatively new implantable device that you see advertised on TV that can be helpful as well. So it's important to recognize it, treat it, work with your sleep doctors. So one thing I wanted to talk about, something that's relatively new, is why is it so important? And it turns out that a lot of this work was done in Alzheimer's. It turns out to be true in Parkinson's. So I want to share this with you. It turns out that people that have Parkinson's disease or Alzheimer's have this I can just do it here. It's all underlying problem is misfolded protein. And in Parkinson's, it's called alpha-synuclein. And you can see here, it's normally an unstructured protein. And then it can misfold and get to these clumps. And it's these clumps that are really important and underlie most of these neurodegenerative diseases. In Alzheimer's, it's called A beta. And in Parkinson's, it's alpha-synuclein. There's also another one called tau. There's a number of these proteins. It's the same concept. These clumps of protein form and become toxic. So what you want to do is you want to get rid of those. So the reason why they also spread from neuron to neuron, so it spreads throughout the brain. We think it starts from the gut, moves up, and then spreads throughout the brain. So anybody who's seen my talks, I always show these slides because it's so important. But I don't want to give a whole talk on the causes, but it does spread throughout the nervous system, these clumps. Now, what's new is that there's one of the ways that we get rid of it is called the glymphatic system. So within the brain tissue, there's neurons, there's astrocytes, which are supportive cells, and blood comes in through the arteries, comes out through the veins. But just like we have in the rest of our body, when there's fluid within the tissue, it drains through a separate system called the lymphatic system. We all know lymph nodes and all that. They're like veins in a sense, but they carry this fluid that gets it out of the tissue. Turns out the brain has its own type of lymphatic system. And we didn't know about it for many years because it turns out that it completely collapses when somebody dies and we fix the brain. So we look at it in a fixed brain and it turns out you can't see it. You can only see it in a living animal. And that's where they found it in mice first. And now we've seen it through MRIs and stuff. And so it's all this space here. And it turns out the reason why it's important in sleep is that when you sleep, so when we're awake, and asleep, we have these aggregates. In this picture, these little brown things, those are amyloid clumps. And what happens is we get rid of a lot of these clumps that are formed by the neurons through the glymphatic system here. And for reasons that we don't completely understand, we get rid of twice as much of these aggregates when we're sleeping than we do when we're awake. Twice as much. So if we keep an animal awake, these aggregates in amyloid or alpha-synuclein accumulate a lot faster because you can't get rid of it as fast. So that's one really important reason why it's important to sleep. is that it helps helps you clear this stuff and helps you from progressing as fast. So I am going to stop sharing because that's the only slides I wanted to talk to. So it's important to sleep, not only to feel better, but to slow the disease progression. So does the glymphatic system work just as well when you sleep if you have to drug induce it with medication? And it turns out, yes, it does. So this has been tested with one of my favorite medicines that we use for sleep, which is trazodone, and it seemed that these particles are cleared just as fast if it's sleep without medicine or with medicine. So there's a couple questions already about some of the medications that we use. So one of them is, what are the pros and cons of Ambien? So Ambien is one of these we call selective benzodiazepines. So Valium is a classic benzodiazepine, um, which is a bit habit forming, not as bad as some barbiturates in the old days. But if you stop it, you do get some mild withdrawals, especially you can't sleep very well. Ambien's a little more selective, so that it's not as habit forming as Valium, but it can be. It suppresses, all these drugs can suppress respiration at really high doses. Ambien isn't so bad at it, but it can a little bit. So when people have sleep apnea, we stay away from these drugs unless they're using CPAP. So the advantage of Ambien is it doesn't last very long. It's short acting, so you don't get that hangover in the morning. That's what is the pro. The con is, besides being a little bit habit forming, is that it doesn't last very long. So it's not uncommon for people that have problems with what we call sleep maintenance or staying asleep, that Ambien just doesn't work for that. And some people will take it in the middle of the night, and then not a good way to go. There's also occasionally people can do strange things. They can sleepwalk. It's not that uncommon. People wake up and they see some food has been prepared, or things in the house are moved, and it turns out they're sleepwalking. So that can definitely happen. So you have to be very careful with that. So it's not one of our first choices for every other night. It's good for sporadic use to help you fall asleep, but it's not a first choice. My first choice for most people, emphasizing over and over again that good sleep hygiene is the key, and none of these things work without that. But I like trazodone. It's a good sleep aid. It's non-habit forming. It's an old antidepressant. Its main side effect is sleepiness, which is what you want. It's very safe. You can start at a low dose and go to high doses safely. Few interactions, and non-habit forming. So that's our go-to for most people, if it's a regular issue. And then there's a whole list of other medications. Um, the long-acting form of Ambien is called Lunesta or Ambien ER. They're the same type of drug. They last longer. We use those if some of the other ones don't work. Restoril is another benzodiazepine, which some people use. Again, it's a bit habit forming. Some of the more expensive, newer ones, Belsomra, also can be helpful for both falling asleep and staying asleep. So I think that's pretty much it, what I wanted to say about sleep. So maybe at this point I'll start taking some questions. So there was a few. One was from Don, who asked about infrared light therapy. There's a lot on the internet about it. So it has to be distinguished between light therapy, which there's studies in Parkinson's that have been done very well, which is getting light during the day so you can sleep better at night. And that is the real light therapy that works. So that's not what you're talking about, Don, but that's the one that a lot of studies were done. The real the light therapy you're talking about is still more in the lab. So that it was noticed some years ago that if you shine infrared light on cells, it activates some genes that cause some neuroprotective qualities, so that they become more resistant to insults, including some of the insults that happen in Parkinson's disease. So the idea is there any way to expose your brain to this type of light in your brain? And that's obviously a big problem, because there isn't a good way. Um, People are talking about surgically implanting lights and all that stuff. I don't think it's ever going to be a practical solution. And shining a light outside your brain, it doesn't get in. The skull blocks it. So anything that they're marketing out there is not been shown to help. Um, so that's the status of that. Um, Don also asked about DBS, and again, there's nothing, I think, clinically available with infrared light now, so I think that's not an important question. But the other question that he asked was the new therapy that didn't get approved recently, which we're hoping about, which is the subcutaneous form of levodopa. So there's two companies, Neuroderm and AbbVie, that are working on this. We were part of the trials with AbbVie, so that's the one I've used, and uh, obviously they support the studies, and that's the disclosure is we're part of the studies, but that the funds go to doing the studies. It works really well. It basically is like an insulin pump. There's a little pump, liquid form of levodopa called phospholevodopa, so that it can stay soluble. It turns into levodopa immediately once it enters the body. You put a needle in the studies, it was every 3 days, but when they applied to the FDA, it's once a day. It's a little injector gun that you just click, puts a tiny little needle in, sticks on with a little sticky, and then you clip a tube onto it and attach it to a pump, and then it gives you 24 hours a day, gives you a nice level blood levels, very similar to the blood levels of Duopa, which is when the pump that puts it into your intestine. This one does it under your skin. So lots of advantages over Duopa. That it's a smaller pump, it's under the skin, you don't need procedures, and it works quite well. So it's been through many trials, and they've been very successful. Main problem with it has been occasional infections from the needle site, but it's very manageable. So why didn't it get approved? So about a year ago, they submitted to the FDA for approval, and the FDA came back and said, no problems with the drug. We think the whole thing looks great. We have an issue with the pump. And that was all they were able to tell me. They thought they would easily be able to address it. A year later, they reapplied and were very confident they were going to get it. They had hired people, all the things that we see happen right before something gets approved. And then we got the bad news that it didn't get approved. And what I've been told is that they have a problem. The FDA had a problem with the factory, not an AbbVie factory, but a third-party factory that makes the pump. I don't know what the issue is with that, and they are fighting back. We're hoping they can get this approved soon. It's already approved in Europe, Japan, Canada, so it's already out there now. So I think it's gonna happen. It's just unfortunately takes some time. So the FDA tends to be on the conservative side relative to some other countries. It's saved a lot of people from bad drugs that have turned bad in other, like thalidomide outside the U.S., but it does delay sometimes some of these newer drugs to be approved. So great drug. Looking forward to it. Was disappointed, but I do think it's going to happen. Um, and it's very similar to Duopa in the blood levels, and we know that that does a very good job in controlling the ups and downs. All right, few others. One from Ryan. What about focused ultrasound? So focused ultrasound um, was actually developed initially by an Israeli company. It was been used actually in gynecology. They were fibroids were actually being zapped with it for years. And basically what it is an array of ultrasound machines all pointing to one place. So along the way, it's not very much energy, but if you have 100 different ones, and I'm just making that number up, a whole bunch of them pointing to the same place, that one little place gets a ton of energy. And when that energy it gets hot, and so if you put that machine in an MRI scanner, you can actually use the MRI to measure the heat and also watch the tissue being burned, basically. So that's what focus ultrasound is. Now, we did procedures called thalamotomy, pallidotomies years ago before DBS. And instead of using a focus ultrasound, we'd stick an electrode in there and burn a little hole. And it helped. You're giving a very controlled stroke. It can help certain symptoms. If it's in the thalamus, it helps only tremor. Um, if it's in the globus pallidus interna, it's called pallidotomy, and that can help many of the symptoms. It's a little more dangerous to do both sides. You get extra side effects, and if you're a little off target, you can get side effects like weakness or problems walking. We've been using it. So a guy in Virginia, Jeff Elias, actually is the one who really developed this along with the company. He was at Virginia, and he it was used, and we've had a machine now for about 4 or 5 years, where it's used mostly for tremor, called thalamotomy, and usually it's only one side. They approved it about a year ago to do another side, but you have to wait. There's a fairly high incidence of transient neurologic symptoms like weakness or gait problems or speech problems. Most of it is mild and most of it recovers, uh, but it's there. It's been approved for pallidotomy this year, but no insurance is paying for that yet. So we haven't done any. I don't think anybody's done any outside of trials until the insurance companies start paying. There are advantages over DBS and disadvantages. So the advantages of DBS are is it's adjustable. You don't hurt any. You don't kill any tissue. Um, uh, but the bad news is that you have hardware, you have to have surgery, it can get infected. Occasionally people get a little uncomfortable with the wires. You got to get battery changes. Um, and for people with called essential tremor, it's different tremor than Parkinson. Sometimes with DBS, they can get what's called a rebound. The brain adapts to it too well. It doesn't seem to happen in Parkinson's, so we're not so worried about that. But it's useful right now, mostly for tremor. So we don't do very much of it for Parkinson's. Doesn't require surgery, but it is giving a very controlled stroke. Still have to have part of your head shaved and put a frame on to go in the MRI scanner. But it's a nice option. I have a couple statements. Gary was saying is sleep apnea, and it's really helpful. The CPAP, it's worth it, and I completely agree. Um, Freezing of gait. There's a question from Susanna about freezing of gait. So there's a couple types of freezing of gait. One type is we call off time freezing. When your medicines are not working and you walking, especially in closed doorways or elevators, it's the most common, but any closed space, especially with anxiety, people's feet get stuck. And taking levodopa usually helps, and that will help what we call off time freezing. Um, the problem is in some people, they'll also start getting what we call on time freezing. So the medicines are working great, everything's going well, but you still freeze. That is one of the hardest problems to deal with. And we have one of our wonderful faculty, Dr. Katie Cross, who's actually studying this in a very sophisticated way. Some people have DBS, have a certain electrode that you can actually record brain waves deep in the brain. And she's trying to learn what's going on in there for people that freeze, because there are cues. So if anybody freezes off or on time, if you give them cues like maybe putting a line on the floor or flashing a light on the floor in front, or even putting your foot in front, that visual stimulus will unstick you and you can step over it. That means that there are ways of overcoming this. So she is working hard on trying to figure out ways of doing that. She has some studies going on that are exciting, but we've yet to solve that problem. Uh, so we optimize levodopa, and then working with a good therapist to use strategies to overcome the freezing. But it's important because it can cause a lot of falls. Have I seen gabapentin used as a sleep aid? Yeah, some of the psychiatrists are starting to use that more and more for a variety of things. Gabapentin is very safe. It was originally used as an anti-seizure medicine, and it turns out it works pretty well for certain types of pain, neuropathic pain, like people that with diabetes, get burning feet. It can be very helpful. Turns out that it can help people sleep. It's not uh, great for everybody. It helps some. Usually people with tough problems falling asleep, I usually find it's not enough, but definitely worth trying. And it's a very safe drug. It's also helpful for anxiety for some people as well. So it's definitely one of the ones that I like to try before getting to some of the benzodiazepines, some more habit-forming drugs, because that one isn't. I think I mentioned Belsomra. I'm looking at Alan's. Uh, Belsomra is one of the newer ones. It works through a completely different system called orexins. And it can be pretty helpful for some people. It's very expensive, unfortunately, and it's hard to get insurance to pay for it always. But it's quite useful. It's a little bit habit forming, but not terrible. Not like some of the other ones. So it can be very helpful. Often doesn't have the hangover. So it's one of the ones I try, but later on, usually because of expense. And once it goes generic, it might be something I go to a little bit sooner. Um, there's a question from Laura about, non-pharmaceuticals therapeutics. I'm not going to talk about any specific ones, but I'm just going to talk about the whole nutraceutical field in general. I like to think of myself as holistic, and to me, being holistic is a healthy diet, exercise, and a good night's sleep. That is holistic. Taking a plant, grinding it up, and putting it in a capsule is no more holistic to me than doing a medication that's either extracted from a plant or synthesized. That is concentrating something else in a pill form. The difference between a nutraceutical and a medicine is that medicines are tested for purity, safety, and effectiveness. When you buy a pill, you know what you're getting. You know how much it is. You can see how often does a certain side effect happen? How often does it help? How does it interact with something? You don't get that with a nutraceutical. every pill might be different. There's been studies showing that you go to any of the health food stores and you pick something off the shelf, half the time it doesn't even have what they say is in it, but it hasn't been tested for safety, hasn't been tested for work, and actually one of the most toxic chemicals is natural. It's called aflatoxin. It's one of the strongest carcinogens it happens. It grows on peanuts. Um, so just because it's natural doesn't mean it can't be dangerous. So I'm not a big fan of nutraceuticals. I find most of them were actually developed by somebody who went on Shark Tank and thought it was a good business model and market it, and not a scientist who studied it and actually find out what it's good for or not. Many of the things that make some sense, like certain vitamins, NAD, coenzyme 210, that makes some scientific sense, has actually been studied, and we study to see if it helps, and we know the safety. So some of them, we know the safety, we don't think it helps, but I'm fine with those. But things that haven't been studied for safety and efficacy, I'm not a big fan of. And unfortunately, they can make claims, it's not regulated, so they can make any claim they want. When it's tested, we actually have data. So I'm a scientist, sorry, and not a believer, but I do think diet and it's so important, and exercise is so important. Just to give you an example, people that eat a Mediterranean diet for decades has half the risk of getting Parkinson's than people that eat a more Western diet. Half the risk. People who exercise daily have half the progression than somebody who doesn't. Just being very active. Those things make a big difference, much bigger difference than if you take some ground up extract of a plant. So I'm a big fan of healthy diets. What about B12 shots? B12, this is Maria. B12 shots are great if you're deficient in B12. If you have normal B12, doesn't help. Is there research being done on polypharmacy interfering with PD meds? Um, Always a concern. PD is a polypharmacy uh, uh, disorder. Unfortunately, it's a cocktail quite often. Um, and so it is important. Yes, we do test for interactions. Um, some we know better than others. Some interactions have been found, during clinical trials and tests. Some are theoretical, so they're warned, say this might do it, and some actually do it. So yes, we have all kinds of databases that I always check and can list all the medications, see which ones are going to interact and not through certain programs. So always should be conscious of potential interactions, which is one of the reasons why I don't like nutraceuticals as well, is we don't know what's in them. So we don't know if they're going to interact. Some of them, like St. John's wort, actually has some medicines in there that are serotonergic that can cause some real problems with interactions with certain medications. So there are examples of nutraceuticals that have bad interactions, and we just don't know about them. What about vibration therapy and the Stanford glove? Um, it's being tested. The glove was got a lot of press where it vibrates and helps with tremor. The studies are being done. It hasn't been well studied yet. I would not be surprised that it helps somewhat, but I'd also be surprised if it lasts a long time. Most of our stimulating devices that we've used work transiently and don't have long, you have to keep doing it over and over again. So it may be useful in the short run. Some of these trials actually are very good at teaching us about the brain, like TMS, transmagnetic stimulation, is sending a strong magnet and can actually activate or block parts of the brain. And that can teach us a lot about how the brain works. but turning it into a real therapy has been more of a challenge. It helps a little bit for depression, doesn't seem to help with Parkinson's, at least in the long run. We've done some long trials with that. A good question here. What about the GLP-1 neuroprotective drugs? So that's a great question, Barry. So everybody knows about the GLP-1s, right? They're the drugs that were developed for diabetes and later for weight loss. It turns out that it has activity doing other things. It lowers inflammation in the brain and interactions with the couple inflammatory cells in the brain called microglia and astrocytes. And there's also some people believe that there's an insulin desensitization of insulin in the brain in Parkinson's, and this may help. So there's been a number of trials testing it. So the reason why it's coming up now is the two big trials were released this year, which I'll describe in a minute. But it started some years ago with one of the GLP-1s called exenatide in the UK. And there's a couple small studies where they took people that were already on levodopa, and which is unusual design for neuroprotective studies. Usually we take people off all drugs before they started a medication because it's a lot cleaner. We don't have to worry about symptomatic benefits from Sinemet and things. But they tried it in people on levodopa. Obviously, that's the majority of people with Parkinson's. And they found that in these small studies that people progressed a little bit slower on exenatide than the people not on it. And they did two trials, both on levodopa, and it seemed to help. So that led to a couple big trials. So one trial was similar to those two little trials, and they had it with people on levodopa. And this was published in a New England Journal, pretty good journal. And it was a well-done study. And they found that it seemed to slow the progression compared to people not on it. That looks great. We were very excited about it, but unfortunately, a few weeks before that, in Lancet, which is another big journal, they did a study, people not on levodopa, so a more conventional trial, and that GLP-1 didn't slow the progression. That one was actually using a drug that was specifically helps get in the brain a little bit better. So what do we do? They're kind of conflicting. So one possibility is that we do know GLP-1s do increase dopamine a bit in the brain. People were aware of that and they tried to control for that in these trials. But the fact that it seems to work better in people or have some effect in people on levodopa, supports the idea that maybe it's somehow improving the function of levodopa. So why not be on it if it might help? And most people are on levodopa. Well, the side effects were quite common in the people with levodopa. More than a quarter of people were vomiting, had terrible nausea. So it also, one of the ways it works in losing weight is it decreases the stomach's contractility. It's called gastroparesis. That's why people feel full. It doesn't empty as well. The problem is that many people with Parkinson's already have that. So I'm very concerned that it's going to shut down the gut even more. So the way I feel about it now is that if you have diabetes or you're overweight and have those indications for it, I think it's definitely worth going on that and trying it because it's clearly not bad for your Parkinson's, and controlling diabetes and losing weight is really good for your health. So, but I'm not promoting it for people that don't have another indication because I worry about the side effects, and so far it's not convincing. that it's got some long-term neuroprotective therapy. But that's the status of where we are. Unfortunately, um, I wish we could give you a more definitive answer. How do I feel about Nuplacid? Is it a good drug for hallucination? I really like it for hallucinations. Hallucinations turn out to be quite common in Parkinson's, especially as people get a little older. It's due to a combination of the medications and the disease. Um, so when people have hallucinations, even mild ones, it's really important to treat them and get rid of them because they will get worse in most people if they're not addressed. And I always think of it um, similar to chest pain. If you're walking and you get chest pain, you sit, rest, it goes away. You don't say, oh, I'm not going to worry about it. You deal with it to prevent a heart attack. And if you see a little bit of a hallucination, even if you say, oh, I see little bugs, but I know they're not real, it doesn't bother me, um, I don't need to deal with it. That's your chest pain. It's going to get worse in most people if you don't address it. So, how do we address hallucinations? The first thing we do is try to get rid of all medications that we can that are contributing. And certain medications can contribute more than others. So, dopamine agonists such as ropinirole or pramipexole or rotigotine, they have a tendency to do it more than levodopa. Uh, Amantadine can as well. We use it for dyskinesias, but that can contribute. So and there's other ones as well. So we try to get rid of those and see if that works. If that doesn't get rid of them, then we have to do it with medications. I like Nuplacid. The generic name is pimavanserin. It takes about 4 to 6 weeks to fully work, but it's once a day. It's really well tolerated for the vast majority of people. It doesn't cause sleepiness in the vast majority of people, and some people actually feel like they think better and they don't mind being on it. So that I really like it for that. The other options we have are quetiapine or Seroquel. It helps people sleep at night, so sometimes we use that if sleeping is a big problem. Um, and then we can use some of the Alzheimer's drugs like Aricept or donepezil or Exon patch. Those things can actually reduce hallucinations a little bit as well. And sometimes we need to do combinations. We have to keep an eye on their heart rhythm. There are these rare instances of what's called QT intervals. It's in your EKG. If it gets too prolonged, it can cause an irregular heartbeat. So we often, if we're using combinations of these drugs, we have to test EKG. What about Crexont? So that's from Gale. So Crexont is made by the same company that makes Rytari. It was just approved. It's not available yet. It's basically a short, medium, and long-acting uh, form of levodopa. Rytari is coming off patent next year. So it's not surprising that the company tries to tweak it a little bit to see if they can hold on to the market share. They tell me that it kicks in a little bit better than Rytari and maybe lasts a little longer. Um, they did not test it in people head on against Rytari, so we don't know until it comes out whether it's better or not. But the good news is that Rytari is going to become generic, which will reduce the price and will make it more available to people. These drugs are crazy expensive, and so the lower the price, the more tools we have to personalize your treatment. Something about GDNF. So GDNF, for those who've been in this world of Parkinson's for as long as I have, maybe a little tired of GDNF. It's a growth factor that had great promise. It's a very small protein called a peptide And in animal models, if we inject it in either through gene therapy or through infusions, it protects the cells from dying. So it's been tried a number of times, both infusing GDNF, similar molecule to GDNF, in different parts of the brain, with gene therapy with it, and it just didn't work. It works when you don't have a control group, but when you have a control group, a placebo group, it's never any better. So unfortunately, there's still people resurrecting it. I'm not enthusiastic about it. And it doesn't cross the blood-brain barrier, so you have to either inject the peptide directly in the brain through a pump that goes directly in the brain, or use gene therapy, which is also injected in the brain surgically. Um, so not a big fan of where that's going. Are there any treatments for apathy that aren't dopamine agonists? The answer is unfortunately no. And dopamine agonists actually don't help apathy as well, at least in the technical term of apathy. So it's hard to separate, what is depression from apathy. They have similar characteristics, but just losing motivation to do things, even if you don't feel sad or depressed. And that can be a function in Parkinson's. We try lots of things. None of them have really helped in clinical trials, everything from stimulants and ADHD medications to antidepressants. Um, I think it's important. I always try antidepressants, especially them, because I think sometimes depression is part of it. So I try to um, I try it, but it's hard. And then you use behavioral techniques, trying to find things that are really interesting to try to motivate, trying to push yourself a little bit, and allowing your partner to push you a little bit. And may feel like nagging, but it's important, because I think it's important not to sit and get sucked into CNN all day and all the things that's easy to happen. So getting out there is really important, but there's no great drug therapy for apathy yet. I take amantadine 3 times a day. How to stop taking it to avoid hallucinations or delusion side effects. So I can't tell you, Gabriel, it can't treat you specifically, um, but in general, if people are having hallucinations or delusions, we try to reduce it and slowly reduce it. I always like to reduce things. And then there has to be a decision. If dyskinesias, it's being used for dyskinesias, they get so bad that you use the lowest dose you possibly can, and then you go to some of the other ways I mentioned to treat the hallucinations, like using pimavanserin or quetiapine. Um, so we try sometimes switching to Gocovri, which is a long-acting amantadine, has slightly lower side effects in some people. So sometimes if we have to use amantadine because they get so bad, the dyskinesias, but the side effects we use try Gocovri, and sometimes that's a little bit better. NAD positive therapy, IV, yes, I've heard about it. It has never been shown to help. It's been shown to be safe. Doesn't help anybody but the bank account of the person selling it to you. Um, you'll hear me, I'm getting cynical over the years. I just get angry when people take advantage. Everybody wants a cure. Everybody wants something to help them. They want to slow the progression down. Um, and we all want that. It just really frustrates me that people prey on, and I don't want to call you vulnerable, but we all are vulnerable to people making claims that are just not based in reality or in science. And there's a motivation for making money. And that really bothers me when there's so many of these salespeople out there. They won't test it. Test it if you believe in it, and demonstrate. And then I'll be the first one uh, um, promoting it. But it's so important to know whether something works and if it's safe before you dive in. So I see I only have a few minutes left. So does anybody uh, have any burning questions that I haven't gotten to?
I have a question.
Okay.
I'm about to start a course of rasagiline, or how do
Is
you,
Sageline?
yes.
Oh,
Is there anything to be aware of in taking those meds?
yeah. So Rasagiline is medication's been around a while. Other people know it as Azilect. It blocks an enzyme called MAOB, and we originally it was designed to hope that it would slow the disease progression down. And in some studies, it seems to maybe do it a little bit in the first couple of years, but after that, it doesn't seem to have an effect on disease progression, or not a big effect, one that we can measure over time. So it has a little bit of benefit. It helps symptoms a little bit. One of the biggest benefits is that it actually can make levodopa last a little bit longer. So it extends it. So if people are wearing off, your medicine's only lasting 3 hours. It may give you a little bit more time. Um, the negative side can be that there's theoretical interactions with certain medications, such as antidepressants. Theoretically, one antidepressant with it is usually fine, but you'll get warnings. We find it safe. So that's one potential problem. And it also can, in some people, make dyskinesias worse. So we always have to balance it. So it's overall a safe drug, well tolerated, very few side effects. Uh, but that's it.
I'm taking the Cinemet and it doesn't seem to do anything. I still have tremor all day long.
All right. So again, I really don't want to give individual advice, but I'll just talk in general. So sometimes Cinemet doesn't work great on tremor. It works great on stiffness and rigidity and slowness, and it can often help tremor, but sometimes it takes really high doses to help tremor, which sometimes you don't want to do. So we try some other medications in that case. And then there are sometimes people don't respond to levodopa, any of the things. It may not be Parkinson's disease. So there's certain tremors, especially the action tremors, and don't often, even in Parkinson's, don't always respond well to levodopa. So we have to try some other medications. Um, and it's also, it matters how much you're taking. So work with your doctor. And if he's not a movement disorder doctor and he's kind of run out of tricks, that's when you want to go to a specialist.
My husband has PD, and the biggest symptom that interferes with his life is low blood pressure.
Yeah.
And I rarely hear that discussed. He's on the maximum amount of medication. And I'm wondering, is there research about this? Is there some
Yeah,
other
great
solution?
question. Great question. Thank you for bringing it up. That's an important one, and I should bring it up more. So this is very common in Parkinson's. It's called orthostatic. So the low blood pressure, when you stand up, it drops and people can pass out. Um,
Yes.
so if it's just low blood pressure, actually that's fairly treatable. If it's always low, we have a couple medicines to try. One of them is called fludrocortisone, which raises the amount, helps you retain salt, raises it. The other and that's a long acting one. So that keeps your blood pressure up higher all day long. Midodrine is a shorter acting one, and that one needs to be taken 3 times a day usually. Um, Now the real difficulty happens when people have periods of low blood pressure, and sometimes it gets high. And that's when then it's a little more difficult and challenging, because if we give fludrocortisone, then it's going to get too high and then gets dangerous. So that's when we tend to use midodrine. for when it gets low. And if it gets high, usually just standing up, walking around brings it down, but we'll use a short-acting medicine to drop it. So it can be a challenge. In most people over time, it's low all the time, and that's something that we can manage with usually midodrine or fludrocortisone. There is a third drug called droxidopa, and that can be really helpful as well. But it is a challenge, and I will tell you that it's something that really is important to address. It means taking blood pressures frequently, finding the patterns, and then using those three tools that we have. So it's tough, but you can improve, and it does get better with time.
My husband takes all three of those drugs and has for 3 years, and it is still such a struggle for him. I'm just wondering if there's any research to extend that.
Yeah. If it's somebody who's very experienced working with it, usually if it's low all the time, we can do it. You can do it usually.
Okay.
Thank you very much.
Thank you so much. I know there's more questions, and I appreciate you all for asking. Maybe we can have Dr. Bronstein back another time, and we'll
Always
address
happy to come back. So,
but I just want to thank you again. This was so informative. I love the component on sleep. It was really important, and I think we all need to know if we have to go get a sleep test now. Everybody should be doing sleep studies. I just want to thank you again, Dr. Bronstein. It was really quite wonderful.
yeah.
Today's event was made possible by our sponsors, Abbott, Acadia, and Boston Scientific. We have some wonderful events coming up, which I can tell you about in a moment. But if you enjoyed today's program, please visit PCLA.org and make a donation. Your contribution to PCLA is critical to our mission to improve the lives of families in our community living with Parkinson's. You can find our contact information on the bottom of this screen. PCLA is a nonprofit, and all donations are tax deductible. And we are doing a special fundraising event through August, so we hope that you will all participate and join us in getting more funds for PCLA so we can put on more wonderful programs like this. We have some great upcoming events. Thursday, September 12th, we have an informative presentation on how neuropalliative care can improve quality of life for people with Parkinson's. Links to register for all these programs will be sent out on our email list, or you can visit PCLA.org and check our calendar. Thank you, Dr. Bronstein. Thank you, everyone who participated, and have a wonderful day.